No, I'm kidding. What I was going to say was, how long are you going to be, do you think? You don't know, but no hurry. But I think if we wait 5 minutes, would that be too much? If we start at 8:05, would that be too late? No? You'll give you enough time for that? Yeah. Okay, good. Yeah, because people ask questions afterwards. And this is good interaction. And for example, person, even though they were here, they said, have we hired an editor? So I said, yes. Yes. Is whom he uses, not that hard. He don't. Yeah. He does quite a few reviews. So maybe she talked to him, and that's why he said, "Oh, we've got somebody else."
That's a good perspective, I guess.
That's a perspective. Now is the glass half full, half empty? Is there a Zoom option today?
I think there is. It's a rainy day. It's thunderstorms and
Crazy. It's almost one. That kind of storm? Yeah. It was a storm. We need it. Natasha, you want to follow the rest of the team?
I actually was texting.
Thank you. Zoom? How many people? And
How are you?
you will present what that you will put up a poster.
I'll submit it, sure.
You know, that'll be something nice. You can just say our experience of starting, rather than talk about the data that you're still trying to get,
Right.
and that you can fill up by the time the poster needs to go up in September or some point. Right, but I don't think so. You're just presenting your experience here.
Yeah, then don't put the data on the post. Just say, it'll be nice because nice to show what you've done and get credit for it. I mean, it is the academy master educator, so they want to see. I think they deserve to see what you've done. Yeah, let's take a look at EKG again. No, I mean, yes.
Good morning, everybody, and welcome to this academic year's Grand Rounds. I'm delighted to introduce Dr. Abhinaya Jawahar. She obtained her MBBS degree from Madras Medical College in India, which is perhaps India's finest medical college. And she topped all through those 5 years and came to this country and did her residency through the University of Massachusetts in Worcester, and then went on to complete a fellowship in endocrinology at the University of Kentucky in Louisville. So now she's going to talk to us about the debunking myths in the treatment of hypothyroidism. Welcome, Abhinaya.
Good morning, everyone. Thank you, Dr. Sethi, for the very warm welcome and kind introduction. And thank you, everyone, for being here on this rainy morning, braving the thunderstorm. And without further ado, let's get started. I hope to present a little bit of information about thyroid disorders, the practical aspects of difficulties physicians face in treating hypothyroidism. I have no disclosures or conflicts of interest related to the contents of this presentation. During this presentation, I hope we are able to address these objectives that I have put forward to identify common misconceptions related to the diagnosis and treatment of hypothyroidism. We will then explore reasons for why this misinformation persists. And then we will analyze the existing evidence regarding frequently disputed aspects of thyroid dysfunction and management. And we will then propose solutions for factual discussion of management of thyroid disease moving forward. So why did I choose this topic? Hypothyroidism, as we all know, is one of the common medical conditions. And almost 65 to 70% of hypothyroidism is treated by primary care physicians, geriatricians, OBGYNs, ENT surgeons, general surgeons. And so it's pretty much something that everybody in the medical field addresses at some point in their practice. And I thought it would be beneficial for us to know the basic facts and myths surrounding this condition so we're able to better answer our patients when they come forward with questions. And we are physicians, we are endocrinologists, we are internists, medical students, residents, physician assistants, scientists, researchers, and we know stuff about thyroid, but we are not our patients. Our patients are a very different group of people who have a very different perception of thyroid disorders. And the questions they have, the understanding they have of the condition is important to highlight when we talk to them about their thyroid issues. And so there's a gap that separates us and our knowledge from our patients. And I hope this lecture is better able to address the gap that exists currently. When you Google thyroid questions on the internet, like I did as a preparation for this presentation, 1.6 billion results pop up. This is a lot. I literally I was not able to read the number. I had to ask my colleague for it. So while most of this information is true, some of it is information we wish our patients did not have. And there's a lot of discordance between thyroid-related conditions out there on the internet as well. So this is a survey from verywellhealth.com, which was published in 2020. And they looked at almost 700 to 800 patients with hypothyroidism. And they asked them how the perception of their treatment by their providers was. 1 in 9 believed that they were being ignored by their providers. And regarding the treatment, only 6% of the patients felt completely satisfied, and 1 in 5 were completely unsatisfied. Only 17% thought that their physician is a good source of support. When discussing their conditions and symptoms, 12% believed their treatment team doesn't believe them. And 43% ended up changing doctors, and 41% believed that they were not being offered all the tests and treatment options that were available. Only 35% felt that they were getting better as a result of treatment, and 73% of the patients felt that almost all aspects of their health, including personal life, were affected because of their thyroid disease. And 45% of them had been receiving treatment for over 10 years. 87% of the people who responded felt that they had to opt for other sources of information like the internet to know more about their thyroid. And this is probably the most intuitive. 38% trusted health websites and 40% trusted their physicians for information. So based on this survey, we are equal to a health website in terms of the information patients get about their thyroid. And I think we are a little better than that. Of course, there is some selection bias in this because it's self-reported patients who have hypothyroidism that responded to the survey, but it's still something to think about to see the gap in knowledge out there. When we graduated from medical school, we took an oath to first do no harm. We can harm our patients by doing something wrong, giving them the wrong treatment, but we can also harm them by omitting to listen to them, omitting to hear them, omitting to hear their complaints, omitting to provide them all the treatment options out there, omitting to give them the time they need. And during this presentation, I've also included certain funny pictures and memes. A, because I thought they were funny, and B, most of us will perceive some of the questions we have from our patients on thyroid conditions to be a little silly. And this also gives a perspective on what our thoughts are as well. Before we get started with this talk, it's also important to review the basic physiology of the thyroid quickly. The hypothalamus is actually the boss, and it secretes the hormone called the thyroid, called TRH, thyrotropin releasing hormone, which acts on the anterior pituitary and results in the release of thyroid stimulating hormone, which acts on the thyroid and causes it to produce TSH and free T4, which are active thyroid hormones, which are then released into the circulation. There's again a concept of negative and positive feedback with thyroid hormones inhibiting the pituitary and hypothalamic hormones as a result of the secretion. So we know this. Coming to the production of thyroid hormones, this is based in the thyroid cells, the follicular cells of the thyroid. And iodine is an important element in the production of thyroid hormones. Iodine is taken up by the thyroid cell by the sodium iodide subporter. And the enzyme thyroid peroxidase catalyzes the iodination of tyrosine residues in thyroglobulin and help in the formation of monoiodine tyrosinases and diiodine tyrosinases. And then they undergo coupling, and through proteolysis, they result in release of T4 and T3, which are the thyroid hormones, into the bloodstream. T3 is the active thyroid hormone, and the ratio of T4 to T3 is typically 15:1. So most of the T3 that we have is derived from T4, almost 80%, and the remaining 20% of T3 is secreted directly by the thyroid. And T4 gets converted to T3 by the enzyme deiodinase. And what are the functions of thyroid hormone? And this is also important for us to know because this will also help us answer some of the questions related to thyroid. So we all know that the thyroid hormone has a permissive effect on the catecholamines in the heart. It increases the expression of beta receptors, increases heart rate, increases blood pressure, increases cardiac contractility, and so forth. And it also stimulates the respiratory center in the lungs, increases perfusion, helps us get all the good oxygen from the air we breathe in. So in pediatrics, it has a huge impact on skeletal growth. It causes increased development of muscle fibers and also promotes growth. And coming to metabolism and thyroid hormone functions. So this is something our patients pay a lot of attention to. So the thyroid hormone increases our basal metabolic rate through the action of sodium potassium ATPase. It in turn stimulates the metabolism of carbohydrates, anabolism of proteins. It increases glucose reabsorption, gluconeogenesis, glycogenolysis, glucose oxidation. So pretty much a powerhouse of metabolism. It also has an effect on fertility through its influence on ovulation. So quickly, how do you diagnose hypothyroidism? The diagnosis is quite straightforward based on all the good assays that we have these days, which are very sensitive. So primary and central primary hypothyroidism is more common, and we diagnose it when patient's TSH is increased. The normal is anywhere between 0.45 to 4.5 units per liter, and it also depends on the assay used, and different labs have different cutoffs. And free T4 level is low or low normal. And in central hypothyroidism, the TSH is inappropriately normal or low in response to a normal or low free T4, low normal or low free T4. And the treatment that's recommended by the Endocrine Society, the American Thyroid Association, and all of the endocrine organizations almost worldwide is levothyroxine. And the typical dose we start patients on is 1.6 to 1.8 micrograms per kg of ideal body weight. And again, it depends and it changes, and we might need to titrate from person to person. So during this presentation, we will address the common myths that are surrounding thyroid disorders. We will see the relationship with thyroid disorders to body weight, and at what time should we take our medicine? Should we take it in the morning, or should we take it with food? What is the best time? And is it really important for us to take it on an empty stomach? And what is the goal TSH that we strive towards in our patients with hypothyroidism? And then we'll talk about combination therapy of T4 and T3. And then we'll address the nutrition related questions that we encounter with the thyroid cases. So the first topic that we will be covering in this lecture will be the effect of thyroid hormone on body weight. I have so many of my patients in my clinic tell me, if only I did not have this thyroid disease, I would lose all this weight. Is hypothyroidism associated with weight gain? Is it a myth or is it a fact? We do have studies looking into this to see if hypothyroidism caused weight gain. Epidemiological studies do not suggest hypothyroidism is more common in those with obesity. In patients with hypothyroidism who were treated to a euthyroid state, they were noted not to have a significant difference in weight before and after treatment. And they also did DEXA scans to look into body composition before treatment and after treatment with levothyroxine, and they noted no difference in body weight following the study. Let's look at some pediatric data. In a study of 1,445 children who were referred for obesity, they looked to see how many of these people had hypothyroidism. It was very low and not significant at all. It was just 0.3% of children with obesity who were noted to have hypothyroidism. And coming to a study with children with thyroid disease, so turning the table around. So you have the thyroid disease, and then you look to see if you gain weight after. So in a group of 117 children, the most common presenting complaint was goiter, and weight gain was rarely noted in this population, and the BMI was comparable to the BMI of the general population. In another study with 29 children with hypothyroidism, again, they were noted to have no difference in body weight with treatment. So where did this come from? So with every myth, there is a deep-seated truth to it. So let me tell you a story. Many, many years ago, probably in the 1940s, we had no thyroid assays to measure the thyroid hormone levels in the body. So when patients presented with hypothyroidism, they came in with myxedema, so fluid imbalance causing them to gain weight because of the edema. So we need to remember the edema and water retention attributed to weight gain in those patients. So it's all water weight and it's not fat mass because thyroid hormone helps with free water excretion. So this is the basis behind the weight gain issue that we encounter with hypothyroidism. So does hypothyroidism cause weight gain? So based on the data that we have, based on the studies that were done, we can safely say that this is indeed a myth. And we are in 2022, as we all very well know, and we are not in the 1940s and 1950s when diagnosis of hypothyroidism is so delayed that we present with myxedema. So this will help us reassure patients that their weight issues are not due to thyroid. So the second myth is regarding the timing of levothyroxine. I feel so proud of my residents when they present to me in the clinic. This is a 42-year-old lady with primary hypothyroidism due to Hashimoto's thyroiditis. She takes levothyroxine, 100 micrograms first thing in the morning on an empty stomach. But is this really necessary? The first thing in the morning on an empty stomach question? Or is it a myth? So we all know that T4 and T3 are absorbed in the intestine, but the mechanism of absorption is still not clear. We do know very well that absorption is decreased in certain malabsorption syndromes like celiac disease, and absorption is increased post gastrojejunostomy syndromes in certain surgeries as well. And it's also important to ask some questions regarding the other medications because these are known to also inhibit absorption of your levothyroxine. Commonly encountered substances are calcium. We need to tell them to take it at least 4 hours after the thyroid medication, iron supplements, bile acid resins, raloxifene, sevelamer, fiber supplements, soy products. These are all known to inhibit absorption, including coffee, which also should be understood and highlighted. So let's look at some data behind the timing of levothyroxine. In 1977, they did a study. They looked to see if there was a change with the absorption of levothyroxine when patients take it fasting without food or when they took it with food. So the absorption of levothyroxine with food was 63%, and the absorption when they were fasting was 79%. So it's almost a 15% difference. It is granted that the absorption is good and better without food, but we should also not forget that the absorption is still 65% when they take it with food. Fast forward 20 years, in 1995, they also looked at some studies which showed delayed peak of levothyroxine absorption with food compared to without. And then in 2009, they looked at another study, again looking at TSH in people who took it when they were fasting and when they did not fast. And the TSH levels in the group that fasted was 1.06, and the TSH level in the group which took it with food was 2.19. Again, the TSH is lower in the group that fasted. However, it's just a 1 point difference in TSH. So both of these are normal values. So we need to understand that absorption still is going on when you take it with food. And this was a study which looked at 84 adults with hypothyroidism who were taking levothyroxine. And this was a multi-center randomized crossover study. And they wanted to investigate the impact of the timing of levothyroxine dosing on biochemical markers of thyroid function, just TSH, free T4, and free T3 levels. So the 84 adults were randomized to 3 groups. Group A took it fasting 30 minutes before breakfast, like we all advise our patients to do. Group B took it 1 hour before their main major meal of the day. And the third group, C, took their levothyroxine at bedtime. And then the data from the study, like we can clearly see, so this is the baseline group A and B and C. So the TSH levels really did not change significantly at all between the groups in terms of TSH, free T4, and free T3 levels. The p-values, as we can see, they're not significant. And this was another study which was done in children. So this was a non-randomized clinical trial, group of 163 children, age 8 to 18, who were treated with levothyroxine for primary hypothyroidism. They all took levothyroxine at fasting to begin with, and then they were given an option to switch over to bedtime dosing if they preferred to do it. And then they looked at the quality of life assessment. So the biochemical parameters, as we can see, for the group that took it in the morning and at bedtime, there was no clinical significance. It was comparable and similar. And when they again asked how they felt and why they preferred to change it to bedtime, few people said that they wanted to eat a bedtime snack. And so they preferred taking the medication in the morning. And some people said, I'm just not a morning person. I barely have the time to get myself out of my home. So I really would like to take it at bedtime when I know I will not miss the dose. And both the groups did report improvement in quality of life as a result of this. And then looking at the special circumstance of the month of Ramadan. So this is a month for the Muslim community where they fast. So they typically eat 2 meals during the day. One is at fasting, and this is the suhoor, which is the meal that they eat to sustain them for the rest of the day. And the iftar is the nightly feast that they have at sunset when they break the fast. So during this period of fasting, the people do not drink water for the most part, and so taking medications is also an issue. So this study looked at the effect of the timing of levothyroxine on the TSH. And this was also interesting in that they compared the TSH values of the individuals to themselves as well at the end of the study. So this was a prospective trial, and the objective was to determine the best time of levothyroxine during Ramadan. So they 50 adults with hypothyroidism, some of them even did not have hypothyroidism under control prior to the study. So they were divided into 3 groups. The first group took their levothyroxine before iftar, 30 minutes before the bigger meal of the day. And the second group took it at least 2 hours after iftar. And then the third group took the levothyroxine 30 minutes to 1 hour before fasting meal, which is the suhoor. And then they compared the TSH values between the 3 groups. As we can see, the TSH did not significantly differ between the 3 groups. And when they compared the individuals to themselves before the start of the month of Ramadan, the TSH again did not significantly change for themselves as well. So it's determined that you can take levothyroxine at a time that suits you best. So coming to the question, so do we need to take levothyroxine on an empty stomach first thing in the morning? So based on the data that we have, I think we can safely say that levothyroxine is best absorbed when when you have an empty stomach, but it's still absorbed when you have food in your system. So take it at a time that works for you. If you're used to taking your levothyroxine in the morning with your morning cup of coffee or your breakfast bowl, take it. If you're used to taking it at bedtime, then take it. So do what works for you best. And I always tell this to my patients, and I have them tell this plan to me when they see me in the clinic. So on the days that you miss a dose, what do you do? So you can either take the tablet anytime on the same day, whenever you remember it, or you can take 2 tablets in the morning the next day, because levothyroxine is a long-acting medicine. So coming to the third myth. So what is the goal TSH? I have many patients tell me that they feel so much better when their TSH is lower. Is this a myth or a fact? So this was an interesting study that looked at normal TSH values in the general population. So this was in people who did not have thyroid disease. This was in people who did not have positive thyroid antibodies, no history of hypothyroidism. So TSH is a very dynamic hormone. So the levels of TSH in any normal person can fluctuate by at least 2 points over the course of the day. Levels are highest in the highest at bedtime, and they are lowest in the afternoon. So your TSH level can be 1 when measured at noon, and it can be 3 at bedtime, and those are still normal values for that person. So based on this study, we see that the normal TSH in the general population varies anywhere between 0.3 to 5, and there are some outliers on either end. And they did see that in older adults, TSH was usually higher. And we also see that in African American population, the TSH is usually lower, and that is normal for them. And we still need more studies to look at why that is so. So we know what the normal TSH is. And this brings us to the question of what are the effects of varying level of TSH on our body. So this was a study that looked to see the impact of TSH on metabolism. So this was done in a group of 138 participants with hypothyroidism. It was a randomized blinded study, and their dose of levothyroxine during the study was adjusted to a certain TSH goal. So there were 3 groups. The first group had low normal TSH between 0.34 to 2.5. The second group had a high normal TSH from 2.5 to 5.6. And the third group had a mildly elevated TSH from 5.6 to 12.1. And they looked at variables at the start of the study and also through the course of the study. They looked at body weight, total energy expenditure through doubly labeled water, resting energy expenditure through indirect calorimetry, thermic effect of food, body composition through DEXA scan, dietary intake by 24-hour food recall, and physical activity through accelerometry. And as we can see at the end of the study, there was no significant difference in any of the metabolic parameters on people between various groups. The only significant difference was the dose change required with levothyroxine to meet the various TSH goals. So no difference between the groups depending on TSH values in terms of energy expenditure, fat oxidation rates, thermic effect of food, and body composition. However, one finding that was interesting was that the people with high normal TSH between 2.5 to 5.5, they were able to do a little more of an exercise. And again, the interesting aspect of this study is that patients, because this was a blinded study, if they thought their dose of levothyroxine was increased, they thought they felt better. And if they thought the dose of levothyroxine was decreased, they thought they felt worse. And most preferred the dose that they thought was higher. And there was not, this data was not reproducible when they actually had the questionnaire. So they were not able to ascertain changes in the dose. So there was no significant difference, but it only changed when they thought they were on the higher dose. And in the same group of people, now that we've talked about the metabolic parameters, they looked at quality of life, mood, and cognition that may have any effect on the TSH levels, because this is a common complaint that we have from our thyroid patients. They talk about their brain fog. So how true is this? So again, in this randomized blinded study, the TSH targets were adjusted and they looked at these neurologic parameters. So they assessed people at baseline and also at 6 months at the end of the study. So during the period of 6 months, their dose of levothyroxine was adjusted to get to the TSH goals. And the items they looked at were a health survey to determine quality of life. It's a 36 short form health survey. And profile of mood states, the affective lability score, and cognitive evaluation based on their memory and their executive function. So after this study, they did notice that there was no difference perceived among participants or seen among participants between the various TSH groups. There was no difference in quality of life or mood measures or cognitive testing. So based on this data, does TSH level affect metabolism and or thyroid symptoms? I think based on this data, we can safely say that this is also indeed a myth. And it's not important to give in to our patients' requests on them needing higher doses of levothyroxine to make them feel better. And it's important for us to explain to them the science behind it and tell them the harmful effects that can happen with over replacement, like atrial fibrillation, increased incidence of osteoporosis, and so forth. So coming to combination therapy. So this is something that's gaining a lot of attention in the recent years, primarily because of influence on social media and all the information that's out there in the internet. Are symptoms improved with combination therapy of T3 and T4? Is this a myth or a fact? So we know that all the endocrine associations and societies recommend T4 monotherapy for the treatment of levothyroxine. And in a group of patients who've had thyroid surgeries done, they looked at their T3 levels, T4, TSH levels, and they saw that they were able to achieve the physiological levels of T3 with patients treated with levothyroxine monotherapy. But we do know that the T3 formulation that we have available, which is liothyronine, it's not the physiological equivalent of the T3 that our body makes. So it is less protein bound, and it also has a very short half-life. So typically more dosing during the day is also required. So the T3 formulation that we have in the market is not as good as the levothyroxine in terms of pharmacokinetics. So this is a graph that shows the number of prescriptions of levothyroxine plus liothyronine, which is the combination therapy that's gone up over the years considerably. It happened in the US, in Canada, Australia, Denmark, and almost worldwide. And again, it's because patients have increased demands. They do demand that they need the combination therapy to help them feel better. And we do see in this graph that though we know that there's not much information with this combination therapy, we are giving into the demands of our patients. And as you can see, the second graph line over here is by endocrinologists, and they are also prescribing increased number of the combination therapy for their patients. So by doing this to our patients, are we doing them good or are we doing more harm? So let's find out. So this was a study that was done in rats who underwent thyroidectomy, and they found that the combination therapy was superior to ensuring euthyroid state in all tissues. There was another meta-analysis of 11 randomized controlled trials in humans, which compared T4 monotherapy to combination therapy, and it showed no difference in a variety of outcomes. 5 to 10% of people who have hypothyroidism continue to complain of fatigue, continue to complain of brain fog. So in this group of population is where we should consider combination therapy as needed. So this was again, the meta-analysis, and they looked to see the effect on combination therapy on patient outcomes. So euthyroid individuals who had the ratio free T3 to free T4 of 0.27 to 0.37, and they looked to see if they could reproduce this ratio via combination therapy on the patient population. So they had to give them T3 to actually get to this ratio. But we can biochemically induce this particular ratio in patients on treatment with combination therapy, but it really did not improve any treatment outcomes or quality of life. So yes, biochemical mimicking the actual T3, T4 ratios is more likely with combination therapy, but there's no benefit from this. And this was another study which was done in 32 adults with primary hypothyroidism who were treated with levothyroxine. And they assessed at baseline and 8 weeks certain parameters while they were on combination therapy. So they looked at thyroid function tests, lipid profile, plasma glucose, body weight, EKG, vital signs, and quality of life changes with combination therapy. And free T4 levels were lower on combination therapy, but there was no difference in TSH or T3. And patients who were given combination therapy were also noted to have a higher heart rate, but there was no change in any of the other variables, and there was no clear benefit that was observed. And this is an older study, but the reason I included it is because it's a large study. This was done out of primary care practices in England, and the objective of the study is to assess the effect of combination therapy on physical, biochemical, and physiological measurements. So they looked at a lot more parameters here compared to the previous study. So this is a double-blind randomized control trial. They looked at 697 participants with hypothyroidism who were given levothyroxine therapy. The parameters they assessed were weight, EKG, blood pressure, resting pulse rate, body composition, thyroid function tests, cholesterol levels, thyroid symptom questionnaires, mood questionnaires, behavioral changes, and physical symptoms of these patients. On combination therapy, it is noted that patients were again noted to have a lower level of free T4. And in this study, they were also noted to have, interestingly, a higher TSH, and they also had higher T3 and T4 ratios. Yes, there are biochemical parameters that change with combination therapy that we discussed previously in the previous study as well. But does it improve the quality of life? So this is the general health questionnaire. So the lower the score, the better. So this highlights the combination therapy, and this is people just on levothyroxine monotherapy. So this was done over a period of 12 months. And at 3 months, people who were on combination therapy did report benefit in symptoms and the quality of life, but this was not reproducible at the end of the study. So there was pretty much no difference. This is another study which I included because it's quite interesting. So this was on a very small and very specific group of patients who had central congenital hypothyroidism, children with congenital hypothyroidism. So they noted that despite treating them with levothyroxine, their TSH continued to stay in the high normal levels, or they were elevated. The free T4 levels were also high normal, so their providers were reluctant with increasing their dose more because they did not want to induce a hyperthyroidism. So these group of children were treated with combination therapy. So the ratio of T4 to T3 was 4:1 in this study. And over a span of 7 months, they realized that indeed the biochemical parameters improved in this group of population. The TSH normalized, the free T4 levels became lower and T3 was higher, and the vital signs improved and patients felt better. So this is a subset of people that we need to keep in mind, especially from a pediatric standpoint of view, and also in patients with congenital hypothyroidism. This is some interesting data about single nucleotide polymorphisms that we see in certain thyroid enzymes. So we don't know that some patients may have these SNPs in some of these enzymes. So in deiodinase 2, there is noted to be a SNP, and this is associated with well-being. And there's another single nucleotide polymorphism in MCT10, which is expressed in the brain. So this study looked at people with these polymorphisms to see if they may have any benefit with combination therapy, and they did. So people in the study who had both these small polymorphisms were noted to 100% improve on combination therapy. Those that had just one of these SNPs had 63% benefit from the combination therapy. So stay tuned for more data. We do need more research in this specific subset of people. So quickly about desiccated thyroid extracts. So this is the popular Armour thyroid that we see in practice. So these are derived from animal sources. So the reason this is not preferred is the ratio of T3 to T4 in animals is very different from what we see in humans. So this can mimic supraphysiological levels, and the absorption is also almost immediate. So this can cause more harm than good is the general consensus among endocrine societies. So answering this question, I think we can safely ascertain that combination therapy is not better than levothyroxine alone, and this is indeed a myth, keeping in mind the exceptions that we saw about the subgroup of patients with single nucleotide polymorphisms and also on kids with congenital hypothyroidism. So if we were to start combination therapy in our patients who have persistent symptoms, American Thyroid Association and Endocrine Society really does not have any recommendations, but European guidelines do highlight some information here. So they say that we can give a 3-month trial to our patients to see if they really will benefit from combination therapy. But if they don't notice any symptom improvement at the end of 3 months, then we have to stop it and we can go back to levothyroxine monotherapy. So how do we determine how much T3 to give our patients? So we take 1/20th of the dose of T4 that they are currently on and give it as T3. You multiply the T3 by 3 and subtract it from the previous T4 dose. So putting this into perspective, so if we have a patient who takes 100 micrograms of levothyroxine, so 1/20th of 100 is 5. So the dose of T3 is 5 micrograms. And 3 times 5 is 15. You subtract 100 from 15, and so the dose of T4 would be 85. So let's quickly talk about the last myth of today, which is nutrition and the thyroid. I had a very lovely young lady in my clinic when I was a fellow, and she was telling me about her Hashimoto's and hypothyroidism and said, I'm generally doing well, but there are a few things I miss out on doing, like eating my favorite Brussels sprout salad. And I asked her why. She said, it is Brussels sprouts. We all know that we shouldn't eat it if we have a thyroid disease. Is it true or is it not? Let's find out. So what are some of the goitrogenic foods that we see? So there is this family of vegetables called Brassica family. So this is usually these cruciferous vegetables like broccoli, cauliflower, Brussels sprouts, some soy, cassava, and so forth. So what do these have, and what is the mechanism behind their alterations with thyroid hormones? So they have this substance called glucosinolate. Under the influence of the enzyme called myrosinase, they get converted to thiocyanate. So these thiocyanate are goitrins. So what do they do and how do they act? When we spoke about the physiology of thyroid hormone production, we saw that the iodide was taken up by thyroid cells by this sodium iodide symporter. So these thiocyanates are competitive inhibitors of the sodium iodide symporter. And so they decrease the thyroid uptake by, they decrease iodine uptake by thyroid cells. And that's how they may cause decreased thyroid hormone production. So this is the basis behind this data. So we do have a lot of animal studies looking into this. There was data from a group of rats who were subjected to a diet that was very rich in rapeseed cakes. So rapeseed cakes have a high amount of goitrins in them. So they said at the end of the study that rats that had higher grapeseed intake did have lower free T4 levels. And then they did a subgroup analysis and found that the rats who did have low thyroid hormone levels were indeed iodine deficient. And in the group of rats that were given iodine in addition to the goitrins, their thyroid hormone levels did not really change. So this is again another study on 72 rats, which were fed various kinds of diets: standard diet, iodine deficient diet, sulfadimethoxine, which is a goitrin, standard plus rutabaga sprouts. Rutabaga sprouts have a high amount of goitrins in them. So they looked at all of these diets to see if they had an impact on body weight or any of the biochemical parameters. And the answer was there was no significant changes. But we know that we are humans and we are different from rats. So do we have any human data on this? Yes, we do. So this is an interesting review article, and they looked at publications over several years from 1950 to 2014 to determine the effect of food on thyroid hormone function. They also looked to see what the concentration of goitrin was in all of these vegetables, and also to see if there is any concern with eating too much of it. And this study also measured the baseline level of goitrins in humans in general, irrespective of what diet we eat. So from this study, we know that the baseline thiocyanate ion in our body ranges from 40 to 120 micromoles. So this is what we have. And after you consume a meal that's rich in goitrins, cruciferous vegetables, kale, and so forth, your level of thiocyanate only increased from 0.04 to 7.3 for the most part. So we see that this is not at all a significant increase in thiocyanates in our body. And in the same study, they also looked to see if there was a specific amount of goitrin that inhibits iodine uptake. So they saw that 194 micromoles of goitrin or thiocyanate was required to inhibit radioactive iodine uptake in patients who were involved in the study. But a smaller amount of goitrin showed no inhibition. So, on an average, these cruciferous vegetables contain anywhere between 5 to 840 micromoles per 100 gram of thiocyanates. So, unless we were to consume a diet that is completely uh, from the brassica class of vegetables, it's very, very unlikely that this will affect our thyroid function. So the human consumption of greater than 1 kilogram per day for several months was what could theoretically affect your thyroid function. So it is safe to say that should you follow a particular diet for optimal thyroid function, this is indeed a myth unless we are a thyroid unless we are an iodine deficient person who is fed a diet just with bok choy for about a month or two or more than that. So now that we have all the data that address the common myths pertaining to thyroid disease, how do we take this forward in order to address the common symptoms and concerns that our patients have? Instead of asking our patients what dose of thyroid hormone they take, how many doses they miss, and if they take it in the morning or not, and rattling on, off and on about our questions, it's good to sit back and shut up for a minute and let our patients talk. Ask them what their questions are, what their concerns are, and give them evidence based answers for the questions that may have. And we may think that treating hypothyroidism is easy and taking a medicine in the morning is a very simple thing to do, but we do not know what battles they are facing and what the practical problems that are involved behind doing it is advised. So it's important for us to go back and ask them about all of this. So as we come to the end of the presentation, I hope we have identified common misconceptions related to the diagnosis and treatment of hypothyroidism. We have explored some of the reasons for the propagation of the misinformation, and we have analyzed the existing evidence regarding frequently disputed aspects of thyroid dysfunction and management. And we will together propose solutions for factual discussion of the thyroid disease moving forward. So we are treating our patients, and what do we do when they still have complaints? So assess other things. How is their nutrition? Are they getting enough sleep? Are they exercising enough, or are they sitting at home being afraid of COVID? So all of this is important. So when we ask them these subset of questions, they will tell you that, yes, this is an issue. I'm not able to sleep. I'm not able to exercise. I eat fast food most of the day. So talk to them about it. And eat your Brussels sprouts salad, eat your cauliflower, eat your cabbage. Do not be afraid. They're all good stuff. And also take your medications. That would also help a lot. So take it in the morning, take it at night, take it at a time that works for you, but take your medicine. And above all, to conclude the topic, I would like to highlight that it's important to be kind and talk to our patients about their questions and then give them answers that hopefully will address all of the doubts that they have pertaining to their thyroid disorders. And with that, I end the presentation, and I will be happy to take any questions that you may have.
Thank you for the great talk. I had a question about iodine deficiency. We're talking about, if you have enough iodine, these goitrogenic foods don't matter. But I was trying to find out the incidence of iodine deficiency in North America. And it looked like the most recent data from the CDC was about 12%. That was like back in the 90s with a trend of actually going down. So I'm curious if you ever check for iodine deficiency, given that it could be a problem in maybe 1 out of 8 patients that we're seeing, and maybe people with thyroid disorders, it might actually statistically be a little bit higher.
That's a good thought. As of now, there's no data about recommendations on checking for levels of iodine in our thyroid patients, because the incidence in this particular region is quite low, because iodine is fortified in almost all the foods we eat. It's not just iodized salt, because I get this question very often, because there's this concept of pink salt being better than white salt, and there's all of this data about influences on social media telling patients do not eat the white salt, it's highly processed and bleached, go for the natural Himalayan pink salt. So they tell, because this salt is not iodized. So I get this often. So do you think I will be iodine deficient if I eat the salt? But I was told this is a better salt to eat. But the answer is no, because it's there in seafood, it's there in milk, in dairy products, and so many of even the snacks that you get over the counter. So from a standpoint of the general American population, iodine deficiency is definitely extremely rare. So, but it will be interesting to study to see if this is in fact impacting any of the thyroid levels in our patients. Yes.
Further questions?
Thank you so much for that talk. I was wondering, so you had mentioned at the beginning of the presentation that hypothyroidism or the thyroid hormone has an effect on respiratory function. And I was wondering if you've come across literature that suggests that hypothyroidism can have an effect, sort of like non-specific dyspnea, perhaps. Like, is it something we should be considering in our patients who have respiratory or breathing complaints that we don't really have a etiology for?
Not really, yeah. But I'll look into it, but not that I came across any such studies. But OSA is common in the population, especially in hypothyroidism as well. So that's something I screen for quite often.
Thank you for a wonderful talk.
Thank you
and
very
thank you
much,
for
everyone.
reassuring me that I can continue to cook with kosher salt. But I have a question for you. The TSH has a fairly profound circadian variation with peak levels at night. So if you take your thyroid medication, your Synthroid at night, you'd suppress that circadian variation. And I'm wondering if there's any literature as to how that might affect the body other than thyroid symptoms.
Good question. So levothyroxine has a very steady peak. So it's a very stable medication. So the half-life is around 7 days. So just because of that, we know that this is probably not an effect on the TSH levels, just because of the pharmacokinetics. But we do see that if sometimes you'll get patients who just come into the clinic the week before the visit, they'll take a lot of T4. And so when you look at the TFTs, you will see that the TSH is probably still high, but the T4 levels are higher. So with free T4, it can have an impact, but not as much with the TSH. Okay, thank you, everyone. Thank you. Wow. Thank you.
I was in high school, we used to do an experiment, tadpoles. We give them synthroid in the water and it makes them become frogs, right? They lose